good evening, good afternoon, good night from whatever you are there. Welcome for our webinar with Prof Colleen Kraft. This is a collaboration between Tariq's Neonatology and Peace Academy. I am very delighted to invite our brilliant speaker, Prof Colleen Kraft. Let me introduce her, and we are very thankful as a group to have one of the wonderful speakers with us. Prof. Kraft is 2018 past president of the American Academy of Pediatrics. Her background include work in primary care, pediatrics, pediatric education, and healthcare financing. Dr. Kraft led a pediatric accountable care program at Cincinnati Children from 2014 to 2017. Her financial model incorporation investment to address social determinants of health, population health data driven quality improvement initiative, and improved payment for primary care service. Dr. Kraft served as interim medical director for the complex care program at Cincinnati Children from 2016 till 2017, where she led a family center designed for the team-based professionals in the care of medically complex children. She was primary investigator at Cincinnati Children's for the Children's Hospital Association Healthcare Innovation Award. Dr. Kraft was the founding program director of the pediatric residency at the Virginia Tech School of Medicine. She developed a healthcare policy and management elective for residents during her time in Roanoke, Virginia, as a center for Medicare and Medicaid innovation advisor. Also, she will introduce us today to the Peace Academy, and let us welcome Prof. Kraft, and let us start our webinar.
Well, thank you so much, Dr. Tariq, and really glad to meet everybody here on the webinar. Where I don't actually work in the NICU, I do work with a lot of these babies once they have been discharged from the NICU. And we're going to really focus today on neurodevelopmental and behavioral surveillance. These are some of my disclosures here. And our learning objectives to recognize the neurodevelopmental and behavioral concerns that arise from prematurity, to identify some of the neuroprotective factors while the infant is still in the NICU, because some of what we're learning is that, in fact, there are things we can do while that baby is still in the intensive care unit that help to protect their brain. And then finally, to incorporate surveillance and screening into the follow-up of these infants. You know, many of the institutions in the United States do have NICU follow-up services, and I'm finding that there are more and more places around the world that are actually now taking these infants and looking at what are the risks that they have, what are some of the services we can provide after they leave the NICU. So if we look at our timeline for prematurity, our neurodevelopmental risk factors increase with earlier delivery. So there's some risk in your late preterm, your baby's born between 34 and 37 weeks of pregnancy. There's more risk if a baby is born between 32 and 34 weeks, a moderate preterm. And then babies born very preterm or extremely preterm are at higher risk for neurodevelopmental difficulties after they leave the NICU. So why neurodevelopmental follow-up? Well, we have rising rates of survival for prematurity, which is great, but then we have more children who are at risk for developmental concerns. And this has long-term impact on families, healthcare, and education systems. And part of the problem is that our preemies face unique developmental challenges. So as they're born prematurely, they have immature brain structures. They are much more likely to have medical complications such as intraventricular hemorrhages or other factors. And then they have environmental stressors. And we're just beginning to understand what is it like to live in a unit without a circadian rhythm or with lights on all the time or sound or some of the other factors there. So how to monitor? What do we need to do for early screening? What do we need to do for neuroprotective care? And then how do we do a structured follow-up of these babies? Brain vulnerability is important because these babies have immature neural pathways. They have underdeveloped cortical and subcortical structures, which make them much more susceptible to injury. And what we know in terms of common complications are intraventricular hemorrhage, periventricular leukomalacia, hypoxic ischemic injury, and then looking specifically at the eyes, retinopathy of prematurity. So what are the domains and risks for neurodevelopment? When we look at the motor domains, we're looking at gross motor and fine motor domains and cerebral palsy. When we look at cognitive, we're looking at intellectual disability. We're learning at later on executive function problems or learning difficulties. With our language, we're looking at expressive and receptive delays. When we look at behavioral and emotional, we have our formerly premature babies who are at higher risk for autism spectrum disorder, for ADHD, for problems with emotional regulation. And then sensory, not only vision and retinopathy of prematurity, but these babies also have increased risk for strabismus and for hearing loss. What about some of the environmental care factors in the NICU? We know that there are stressors for these babies for sensory overload, painful procedures, maternal separation. And one of the neuroprotective strategies that's being used really all over the world is kangaroo care. How do we do skin to skin work with babies and their mothers or their fathers or somebody else who's a close family member? How do we use these neuroprotective strategies in clustering care, promoting skin to skin contact, and optimizing sleep wake cycles to help minimize pain? So when we look for tools for neurodevelopmental monitoring, I can't underscore clinical examination and surveillance. As we get into higher technology with these babies and you're looking to follow up, there are lots of things like MRIs and ultrasounds, but we are doctors. And the basic clinical exam, the neurologic exam at NICU discharge and follow-up visits is a core competency for what we need to use to follow these babies. And so regardless of where you are, your physical exam remains a super important tool in the follow-up of these children. We look for growth and milestone tracking in the primary care setting, and then longitudinal monitoring with risk stratification based on these NICU complications. So the American Academy of Pediatrics put out a paper in 2023, and this is called Primary Care Framework to Monitor Preterm Infants for Neurodevelopmental Outcomes in Early Childhood. And I'm going to go through this figure a little bit because it looks at age of delivery and it looks at complications and helps you through an algorithm to look at what you need to monitor for these babies. So it is a neurodevelopmental risk stratification framework for infants who are born prematurely. And this is just blown up on through here. So if you have a baby born at less than 28 weeks gestation, you already automatically have very high risk for cerebral palsy, for visual impairment, for hearing impairment, and for intellectual disability. And that continues even if you have a baby who's born greater than 28 weeks gestation, but they have hypoxic ischemic injury or periventricular leukomalacia, or retinopathy of prematurity, or moderately severe bronchopulmonary dysplasia. That risk decreases a little bit if you just have a grade 3 to 4 IVH or necrotizing enterocolitis. So that second block looks at high risk for cerebral palsy, visual impairment, hearing impairment, but a little bit less risk for intellectual disability. And then as these risk stratifications change, This is moving down the curve. So as you have a baby who was born at 28 to 31 weeks gestation, you're going to have high risk for intellectual disability and hearing impairment, but lower risk for visual impairment, still very high risk for cerebral palsy. As that baby's gestational age increases to 32 to 36 weeks, you have lower risk, but still risk for cerebral palsy, visual impairment, intellectual disability, hearing impairment. And as that baby gets to that late preterm stage, gestational age greater than 37 weeks, then there's no added risk at the end. When you look at the neuroexam components, early on, and as that baby is discharged, alertness and arousal is important, the ability to waken with gentle stimulation. That clinical importance is that poor arousal or irritability can signal neurologic dysfunction. Looking at cranial nerves, eye movements, facial sensation and rooting reflex, sucking and swallowing, because that really is a very basic clinical exam for cranial nerves 5, 9, 10, and 12. Looking at tongue movements. And again, if the cranial nerve function is weak or absent, there may be some brainstem immaturity or injury. Muscle tone is important to look at for these babies. If the resting tone for preterm infants, it usually shows hypotonia versus term infants. But as that infant develops, you should have increased active tone. And you can use the vertical and horizontal suspension test to assess for central tone. Because it's persistent hypotonia or asymmetric tone that may indicate cerebral palsy risk early on. As you look at strength and sensation and spontaneous movement, anti-gravity movements are that baby's ability to lift their arms and legs against gravity. And the symmetry of those movements is important because asymmetry will suggest a focal brain injury. So weak or absent spontaneous activity is a concern for developmental delay. Response to light touch or gentle pressure, if there is localization or withdrawal, also important because an absent response or an exaggerated response can reflect peripheral or central nervous system issues. And again, looking at those babies' reflexes, we know that those babies are born with the primitive reflexes, the marrow, the root, the grasp, the stepping reflex, the gallant, and the deep tendon reflexes. We want to see these reflexes early on. We want to see them generally once these babies are being discharged. But in follow-up, if there are persistence of the primitive reflexes beyond that expected age, or the absence of reflexes, it may indicate abnormal neurodevelopment. So, question number 1. You are examining an infant who was born at 30 weeks of age of gestation. That baby did not have hypoxic ischemic encephalopathy or bronchopulmonary dysplasia or periventricular leukomalacia, but he did have a history of necrotizing enterocolitis. So this child is at very high risk for cerebral palsy, hearing impairment, vision impairment, intellectual disability, or 1, 2, and 3. And again, if we look back at that algorithm, I'm going to move back a little bit here to the algorithm. If we look back at the algorithm, that baby is more than 28 weeks gestation, has necrotizing enterocolitis, but does not have HIE, PVL. So that baby is actually at very high risk for, if you look up here, for cerebral palsy and visual impairment and hearing impairment. So the answer to this question is actually 1, 2, and 3. Again, using that algorithm for predicting what you need to be following for neurodevelopmental difficulties. Question number 2. An abnormal neurologic finding of a 4-week-old, former 34-week gestation infant includes an intact Moro reflex, an intact grasp reflex, asymmetric movement, right side versus left side, or hypotonia. And the answer to that is asymmetric movement, because you would expect a former 34-week-old who's only 4 weeks old now to still have an intact Moro reflex, grasp reflex, and they are still going to be relatively hypotonic compared to a term infant. But asymmetry at this age is always abnormal and would prompt an investigation. So we're going to talk a little bit about some of the developmental surveillance and screening that we do. Developmental surveillance is that continuous longitudinal monitoring of a child's developmental progress. With my primary care colleagues, I talk about this being the third leg of pediatrics. So if a child came in to see you for fever or cough or some other reason, and they had a third leg, you would say, oh, that baby has a third leg. There's a problem here. Same thing with developmental surveillance. So you have a 3-year-old who comes in to see you for fever and cough, and they're in a stroller because they're not walking. That development is their third leg, and you have to be thinking about more than the fever and cough. You have to be thinking about, why is that child in a stroller at 3 years of age? So developmental surveillance is that longitudinal continuous monitoring of a child's progress. Developmental screening is something you do when you're concerned about something you find on developmental surveillance. So it is a formal, structured assessment using a validated tool. And that the follow-up of premature infants usually involves more routine screening because we know that we're going to be screening for developmental problems. And so having some screens in place that are validated for that baby's age and former gestational age is important. There's a great calculator from the Neonatal Research Network, and I've got I have the URL up on the top through there. But this is a way that you can really look at an age-adjusted age for that child given their prematurity. So a baby who was born on July 4th, 2025, and then the developmental test date is today, 12/12/25, and that baby was 32 weeks and 2 days. What that calculates out is the adjusted age for the test and then the chronologic age. So that baby's chronologic age is 5 months and 9 days. But if we adjust the age for developmental testing, which is important to do, because you're not going to expect a baby who was 32 weeks gestation to be caught up to the same development as a baby born at term when they're 5 months old. That baby's adjusted age is going to be 3 months and 16 days. So if you look at the 18-month adjusted age and the 22.5-month adjusted age, it's going to be a little bit closer to making up for the prematurity. But this is a great neonatal calculator. So when you see these babies in follow-up and you know when their date of birth is and you know where their prematurity is, you can calculate where you should be testing for that adjusted age. And so this is what you would be looking at for this baby. You really look at the adjusted age, which is on the left-hand side. For 3 months, that baby should be regarding the face and cooing and tracking visually and lifting their head briefly. This is not a baby that you would assess for 5-month skills, which would be more like rolling over front to back, cooing, reaching. So it's really a good thing to have the adjusted age and then to have what you should be expecting in terms of milestones for the adjusted age of that baby based on prematurity. So again, adjusted milestones for a 4-month-old, they would only be beginning to grasp for objects around and then laughing out loud. Where our baby, who was a 32-weeker, a 4-month-old adjusted age would be a 6-month-old chronologic age, but you would look at their development based on the adjusted age. So when we look at screening, screening again is the use of that brief, objective, validated instrument. And the goal is really to differentiate children who are probably okay versus those who need additional investigation. And really looking at those with unsuspected deviations from normal. It's performed at a set point in time. It's an objective impression versus a subjective impression. But the results have to be interpreted in context. So if you do a screen and a screen is abnormal, but with your clinical knowledge, it seems to be okay given that baby's age or adjusted age, then you may not have to worry. So it's never in isolation, and it's in aid to ongoing surveillance. It is somewhat of an art, although it does give you some very good information. So some of the developmental screening tools that we have out there include both parent-completed questionnaires and directly administered instruments. And both are valid. There's a lot that you get from asking the parent what a child can do. One of the things that I notice is that the parents who can complete that and know what their child can do are really much further ahead, and they're much better able to actually take counseling in terms of what you need to do to help your baby's development. Your directly administered instruments are things that you actually observe what the baby is doing. When you look at standards for screening tests, the accuracy to categorize is measured in sensitivity, which is the accuracy of the test in identifying delayed development. And then the specificity, which is the accuracy of the test in identifying individuals who are not delayed. So for developmental screening tests, we're looking at a sensitivity and specificity of 70 to 80%. We want to pick up all of those kids who might have a delay, and we want to rule out those kids who probably do not have a delay. So some of the developmental screens by age. In the neonatal period, preterm babies to 1 month of age corrected. The assessment of preterm infants' behavior is a specialized tool that we use for neurobehavioral assessment in the NICU. And then we also will use the neonatal behavioral assessment scale that really, again, looks at those reflexes, state regulation, and social interaction. So it correlates nicely with your physical exam skills. Many of the babies that I see in follow-up in that 0 to 18-month corrected will be looking at the Alberta Infant Motor Scale, which looks at gross motor development from birth to 18 months and does a nice job of picking up children where we may have concern of cerebral palsy. The Bailey scales of infant and toddler development are very commonly used in the United States and other places as well too. That is a more comprehensive evaluation of cognitive, language, motor, and social emotional domains, and it's validated between 1 and 42 months of age. And then the general movement assessments is an early detection of cerebral palsy risk. And again, these are babies who are below 5 months of adjusted age. The neonatal behavioral assessment scale, this is what the picture looks like here. This came from Boston Children's and Dr. Brazelton. And this assesses the newborn's behavioral scale in 28 questions. There are 20 questions that support neurologic function as well too. And so it begins to look at autonomic regulation, motor organization, state organization. Is that baby responsive? Is that baby irritable? And then attention and social interaction. The Bailey Infant Neurodevelopmental Screener is nice in that it takes about 10 to 15 minutes to do. It does look at those neurologic processes like reflexes and tone. It looks at neurodevelopmental skills like movement and symmetry, and then developmental accomplishments. When does that baby have object permanence? What about imitation? When do they imitate the tester? And what do they have in terms of their language? So cooing, babbling, along those lines. There are 10 to 13 directly elicited items per 3 to 6 month age range. And it categorizes the performance into low or moderate or high risk cut scores, and then provides subtest scores for each domain as well too. So you can use this in babies from 3 to 24 months. So this is really what the testing looks like. So you look to see for a 3 to 4 month old, does the eye follow a ring? Does that baby reach for a suspected ring? Do they hold their head erect and steady for 15 seconds? What do they do with their head if you ventrally suspend them? What do they look like in terms of optimal muscle tone in the upper and lower extremities? Do they vocalize more than one sound? And do they demonstrate coordinated movements of extremities? And so you would look in that total age score, and you can tell for that question and for that age whether that baby is at high risk for a problem, at moderate risk, and at low risk. So the Bailey is something that is commonly used in our neonatal follow-up clinics for these kids. And again, it's something that you can look at based on that child's age, and the score will change with that child's age. There are some early childhood screening tools as well too, and many of these are actually used in our primary care offices here in the United States, but they can be used in neonatal follow-up as well. The Ages and Stages questionnaire is one of the parent-completed monitoring systems, as opposed to the Bailey, where we actually do the screening ourselves and the testing ourselves. It's completed across the domains of gross motor, fine motor, social emotional, language, and problem solving. There's another test that's called the Parent's Evaluation of Developmental Status, which is also, again, a broad parent report tool. These are some sample questions from the Ages and Stages questionnaire. So when your child wants something, does she tell you by pointing to it? Yes, sometimes not yet. Does your child say 8 or more words in addition to mama, dada? Yes, sometimes not yet. So again, these are really looking at older toddlers and some of the things that you would expect them to do. With the scoring, we assign a value of 10 to yes, 5 to sometimes, 0 to never, and that you can add up the scores and look to see where that child's total score is in the communication, the gross motor, the fine motor, the problem solving, and personal social. Another screen that we use very commonly in the United States is called the Survey of Well-Being in Young Children. And the thing I like about this one is it looks at development in terms of milestones, and then what's called the parent's observation of social interactions, which we can use as a kind of a proxy for social emotional development. We ask the family questions, so we get family history, we get family living conditions, social determinants of health. And then in behavior, there's the baby pediatric symptom checklist, as well as the preschool pediatric symptom checklist for older toddlers. The nice thing about the Survey of Well-Being in Young Children is that it is in the public domain, and it actually comes into many different languages. So it comes in English, but it comes in Spanish. A lot of my families are Spanish speaking. It comes in Arabic, it comes in French, it comes in many different languages. And you can find it online. So you can use this to test any of your babies in follow-up. So question number 3. An 8-month-old former 28-week gestation infant sees you in follow-up. So they're 8 months old now, 28 weeks gestation. So you know that this baby's adjusted age is about 12 weeks behind. Which developmental milestone would you find most concerning? The infant doesn't sit alone. The infant will reach and grasp with her left hand, but not her right hand. The infant doesn't seem to turn to noises, and the infant isn't babbling yet. Or answers 2 and 3. Well, this one is really answers 2 and 3. Because again, an 8-month-old, 28-week gestation, you're really looking at that baby being about 5.5 months of adjusted age. So you would not expect a 5.5-month-old infant to sit alone. That one's okay. But the fact that that baby is reaching with her left hand and not her right hand tells you there's asymmetry. So that is always abnormal. A 5.5-month-old should be turning to noises. And the fact that that baby isn't doing that makes you wonder about that hearing. And the fact that the baby isn't babbling yet, a lot of times we don't see babbling and consonant sounds until over 6 months of age. So that is developmentally normal. So with this question, that 8-month-old, former 28-weeker, development is concerning if that baby is reaching and grasping with her left hand, but not her right hand, and she's not turning to noises. So evaluations for concern. This is where we reach out to some of our other subspecialists. When we have concerns about gross motor delay, we will often reach out to our neurologists because they will really look at the motor tone, milestones, risk of cerebral palsy, seizures, or intraventricular hemorrhage sequelae. And they really need to follow up to see what's happening with this baby long term. Likewise, our ophthalmologists, if we're concerned about vision, that those babies may have retinopathy or prematurity. And that screening begins in the NICU and continues until retinal vascularization is complete, with interventions if needed. But there are later evaluations for strabismus, refractive errors, and amblyopia. And these are things we see very, very commonly with our formerly premature babies. Audiology is another big problem because hearing has everything to do with development. There are some places that have universal newborn hearing screening in the NICU. The United States is one of them, but I know a lot of places around the world that do not. And so diagnostic audiology for infants with specific risk factors is important. So a baby who's been on, say, gentamicin because of suspected sepsis, or there has been prolonged ventilation, or that baby has had meningitis, all risks for hearing loss. And those are babies that you would want to do audiology testing before the baby leaves the NICU, and certainly follow as a risk factor for audiology. And then we're looking at ongoing surveillance for speech and language delays for these children as well. Physical therapy. Physical therapy is actually a very good intervention for a lot of our NICU grads, but particularly those where you're worried about motor delays. So that baby who isn't rolling or sitting or crawling or walking at corrected age milestones. And again, corrected age milestones. If even before they're not making those developmental milestones, they may be hypertonic or stiff. They may be hypotonic or floppy, or they've got any asymmetry in movement. Really good to get physical therapy involved. Postural head control issues, so poor head or trunk control or persistent head lag, very good to get physical therapy involved. Some of the orthopedic concerns, babies that have torticollis or that tightening of one of their sternocleidomastoid muscles or atypical gait patterns as they get older. And certainly any baby with a history of brain injury. So intraventricular hemorrhage, periventricular leukomalacia, or other cerebral palsy risk, all of those babies who have that high concern for cerebral palsy or intellectual disability should actually be seen by physical therapy. As we know, there's a big connection between motor movement and our intellect and our other senses. So getting those babies who are at risk into physical therapy for some exercises is a good idea. Speech therapy referral is indicated when those infants show delayed babbling or vocalization beyond corrected age expectations. We begin to see a lot of our babies, once they are at the point of discharge, having difficulty with feeding and swallowing. And some of these babies are big aspiration risks, have poor oral motor coordination. Many of these babies have language delay, limited vocabulary, or poor comprehension, or if they are not having gestures by toddlerhood. And we specifically are looking at that adjusted age of 12 months. Those babies should have what we call joint attention, which means that they want to get a parent's attention to show them something. Usually that's going to be by pointing, by doing some things to get that parent's attention. And if they are not doing that by 12 months of age, then you worry about that social emotional communication. Those babies who don't have joint attention by an adjusted age of 12 months are at higher risk for autism. And other social communication concerns. So poor eye contact. And looking at poor eye contact while you're looking for stigmata of retinopathy or prematurity, because if you're having trouble seeing, you're not going to make great eye contact. But lack of joint attention or limited interaction is important. So these are all good reasons to have a speech therapist as part of your treatment team. Occupational therapy is indicated when you have babies that are specifically showing those feeding difficulties. And we do tend to see this with some of our NICU grads. They have that very poor suck, swallow, breathe coordination, take very long to feed through a bottle, or they have aversion to certain textures. Some of these babies have sensory regulation issues, so they have hypersensitivity to touch or to sound or to movement. And often what shows up at this, these babies can be very irritable and they have difficulty calming. There are a lot of occupational therapy types of interventions, some of the wrapping or weighted blankets or swings or other things like that that really do help out these babies. Many of these babies have risk for fine motor delay, so trouble grasping or reaching or manipulating toys or being able to feed themselves at expected corrected ages. And then self-care challenges, so difficulty with hand-to-mouth skills, play routine, sometimes even dressing as they get a little bit older. But these are all good reasons to have occupational therapy on board as one of your treatment teams. And then behavior therapy. Many of these children do need behavior therapy because of some of their regulation difficulties. These are babies that often will have persistent irritability, poor sleep-wake cycles, difficulty self-soothing. And you'll know this because the parents will tell you that there's limited engagement, that these babies are just so fussy at home and nobody is sleeping and everybody is stressed out. As they get to be toddlers, they may have excessive tantrums or aggression or withdrawal. And certainly any of the autism spectrum red flags, poor response to their name, repetitive behaviors, lack of pointing, may all be reasons to have a behavioral therapist as part of your treatment team. So question number 4. At 12 months adjusted age, your former 32-week gestation patient is not pulling to stand, not responding to his name, not trying to feed himself. He does babble, but doesn't seem to interact with his parents. His motor tone seems intact. So appropriate referrals include audiology, speech therapy, occupational therapy, all of the above. And the right answer for this one is actually all of the above. So this baby is 12 months adjusted, but they're not pulling to stand, which tells you maybe something about balance, and occupational therapy could help with that. They're not responding to their name, which makes you wonder whether they're having trouble hearing or whether they just have a speech language delay. And that's a good reason for checking out audiology and speech therapy. And he's not trying to feed himself, which again makes you wonder about occupational therapy and their fine motor delay. The babbling is good, but doesn't seem to interact with their parents. So again, speech and occupational therapy are going to be very helpful. And that he's got good motor tone, which is a good thing. But these are all members of this team that you would want to get engaged with this particular child. So when you look at neurodevelopment follow-up for preemies, you want to know the risks based on the NICU history and course. You want to be sure to calculate the adjusted rate for developmental assessments. So using that neonatal calculator where you can put in that baby's gestational age, that baby's date of birth, and then figure out what their adjusted age is when you're looking at developmental screening or developmental assessment. Knowing that there should be frequent follow-up in the first year of life. And then know when to refer to your subspecialists like neurology, ophthalmology, know when to refer to vision and hearing, and know when to refer to occupational, speech, behavioral, physical therapy. And with that, I will say thank you. That's the formal presentation. I really appreciate everybody's attendance and welcome to have some questions.
Yeah, actually, I was like very comprehensive and very nice. And for me, as a person who work in ICU for a long time, I think we are not doing the proper job for behavioral assessment inside the NICU. As I'm talking about myself, we come every day and examine the babies, put a plan and put a plan for discharge or for weaning of ventilation or start feed or whatever. But and we do like a formal exam, but we didn't concentrate about this behavioral assessment, and even the pain score we leave it to the nursing staff. So I will start my question till I have some question in the answer and chat about uh, which gestational age you start to follow up this baby, because the guidelines is different from an institute to another. So if you have a baby with 32 weeks, this will need a neurodevelopmental follow-up at 2 years, or which exactly the gestational age these babies need a neurodevelopmental follow-up, especially at 2 years of age.
So you're asking about a former 32 weeker who's now discharged from the NICU and is just in the community. So many of these babies, we will start to do monthly follow-up for the first 2 to 3 months, see how they are doing, see how they're adjusting at home. Because a lot of that neurologic follow-up, the first thing is really going to be how they attend to their parents, how they interact with their parents. Are they overly irritable? Are they too sleepy? Are they responsive at all? And then we'll be looking at some of their developmental milestones and then using something like the Bailey scales to get us a specific gestational age or concern. And as we have that first visit, then we can really talk with the family in terms of what we need to do with more follow-up and where our concerns might be. And would this baby benefit from physical therapy or speech therapy or occupational therapy? Um, in the United States, we do have a system called early intervention where if we see these babies and they are at risk for certain delays, we can actually get them involved with early intervention as well too. But even just having physical, occupational, speech therapy, behavior therapy as part of your team, you can look at those babies when they first come out. Generally, we'll see them again a month after they're at their discharge to make sure that their neurodevelopment is going well as some of the other things like that they're growing, that that they're staying well in terms of their other parts of their physical exam.
Oh, thank you. I have some questions on the chat box, so I will start read the first one. Some comment initially, excellent presentation, thank you. Then we have Dario asking about, do you believe the PINS remains a valuable screening tool, given that it is validated in 1995 and its cutoff scores may no longer reflect current developmental standards?
So that's a great question. This is about the Bailey as well. And the Bailey is one of many different screening tools. It has been a standard and it was developed, it was validated back in the 90s. But a lot of people will still use it because it does give you some good basic information. Um, in terms of other scores to follow up with, there are a couple of different other screens that we will sometimes use. But the Bailey's a good one to start with. And as you find other screeners that tend to be a little bit more up to date in terms of their validation, it is fine to go ahead and use those as well too. Some people will move on to something like the ages and stages or the PEDS or the SWIC to actually look at other types of reflexes, other types of developmental milestones.
Thank you so much. Let me also announce that this webinar is recorded, and I will submit now on the chat box the feedback form. And once you submit your feedback, you will get a certificate from Tarek's Neonatology that you attended this course. Magid also have a question. You can say your question by yourself, Magid, please.
First of all, thank you so much for your great presentation. So my question is about the proper follow-up plan for a premature baby who was discharged from the neonatal unit with a neonatologist, I mean, not with occupational therapy or with any other specialty.
So you're looking at when should we be following up our formerly premature babies? Is that the question?
Yes. Yes.
Okay. So
So how
really
often?
given the risks that baby has, given what their course has been, usually we will start to follow up these babies sometimes weekly when we're looking at weight, but then monthly until we really are stable in terms of their neurologic development. Just because neurologic development is dynamic, and that we sometimes actually see once babies go home and they're with a very interactive family that their development seems to really improve quite dramatically. And then we sometimes see in families where there are some other difficulties that we have problems with development. I think that it becomes a very individual decision, but I start usually with weekly for weight checks and then monthly for 2 to 3 months to make sure that baby is progressing the way that we would want them to.
Well, thank you so much. Very clear. Also, I want to, before going to the coming question, I want to highlight what you mentioned about NEC. And because, we concern about necrotizing enterocolitis, and this is one of the nightmares in ICU. But the
Yes.
point here is they are prone to a lot of problem, like you mentioned about cerebral palsy, hearing impairment, and visual impairment. And actually, we don't like to these babies from this aspect. Do you think that we should, once baby had proven NEC, we should discuss with the family separately about that they may have, even they are look nice after that, they may have this impairment?
So when you have a baby with necrotizing enterocolitis, you have that confounding factor of nutrition with everything else there. And so, those are babies that you certainly will follow them for neurodevelopment because they are at higher risk for cerebral palsy and vision and hearing impairment. But at the same time, you might want to actually follow those babies up a little more frequently because of their weight and nutritional status. And you know that they're less likely to absorb all of their nutrients, that they may have trouble with weight gain, they may have trouble with getting the right calcium and vitamin D into their system as well too. So that disability, you confound a lot of things, and there are a lot of things you need to follow up with those children. So a little bit more frequent follow-up, especially in the very beginning, is something that is going to be very helpful. As that child is gaining weight regularly and is developing normally, then you can space out the time that you see them to even match the regular well child check schedule.
Thank you. So we have a question from Prakash. I think, yes. Prakash is mentioning, at what corrected age should a neonatologist transfer care for further long-term follow-up with other colleagues?
That's a really good question. The question is at what age should the neonatologist transfer that care to other colleagues, like a primary care or a follow-up clinic? And the answer is really based on the resources that you have locally. So many places we do have the follow-up clinics tend to be run by a neonatologist and a developmental specialist, and then sometimes just a general pediatrician as well too. And that team really looks at when does that child need to continue to be followed in the follow-up clinic versus when could they just be followed by their doctor. In the United States, we have primary care pediatricians, and so you can be followed by a pediatrician. But in other places in the world, and even the UK, there are some places that a general practitioner can actually follow that baby just fine. And I think that the team of a neonatologist, somebody who is versed in development, and then a regular pediatrician can assess when that baby can actually be transferred over. So not a particular age, very much related to that baby status, how the baby is progressing, and what the resources are in your community.
Thank you so much. Also, another question from Dr. Tajuddin Ali. Yes, very well known in the Middle East. Ali, thank you so much for your help and support. Appreciate your cooperation. This only appreciation from Dr. Ali. Another question from Hala. Thank you so much. Is the time that the baby on ventilator and later on O2 will affect the degree of cerebral palsy?
So babies who have bronchopulmonary dysplasia, which you would really look at as they're being oxygen dependent after a certain amount of age, those babies do have very high risk for cerebral palsy, for hearing impairment, for visual impairment, and for intellectual disability. And that's one of the nice things about that algorithm from the American Academy of Pediatrics paper is it kind of gives you an idea of what sorts of things you should be following to follow up with these babies. So that's a baby that you're going to want to watch for all of those things.
Thank you. And actually, we have like in here in Leicester, UK, we have the special clinic for the BBD babies, and also in the same clinic will be a dietitian, and it will be a combined management from the respiratory side and for developmental side, and also from the nutrition side. So
That's amazing. That's
yeah,
great.
yeah. Again, question from Prakash. Any practical suggestions to help the parents of a child needing to visit multiple clinics at different time interval?
So that's a great
Yeah,
question too, is that a lot of these babies wind up having to see a pulmonologist and a neurologist and somebody else who may be, part of that baby's care. Sometimes what you wind up having to do is sit down with a parent and look at who are all the specialists that you need to follow up with. Because in fact, if your weight is going to get checked in neurology and in cardiology and in pulmonology, then parents we can just keep track of where that weight is. If they're all within the same system, you can do it through your own electronic medical record. But if not, then I usually get parents to monitor where their weight is. And then with development, generally, if they're seeing neurology, development will be something that will be checked. But I think that you can work with a family so they don't have to see you every month if they're already going to be seeing other specialists during that time too.
thank you. Thank you so much. Again, Hala is asking, is the degree of gastroesophageal reflux will be a factor that affects the neurodevelopmental growth is as it may struggle to feed well?
So that's a great question. Is there a correlation between the degree of gastroesophageal reflux and that baby's neurodevelopment? And really the answer to that is that can actually be something that is variable. You can have kids who will have good neurodevelopment, but will struggle with gastrointestinal reflux. And then you can have that interaction where you've got a baby whose development is delayed in their gross motor. And because of that, they're not able to sit up well. And so that exacerbates their reflux. And so you have to take a look at all of their factors together, but look at the interaction too.
Yeah, thank you. While you are talking, you mentioned about the primary care from framework to monitor the preterm, the algorithm which is started 2023, and I find it very helpful. And I think if you share the main paper later on, then we talk about innovation and AI because we can make a calculator or a kind of risk predictor from this paper. And with AI, it will be very nice if we share this paper. And I promise I can do it.
Okay, I will send you the paper and let you share it with everybody who's on the program. Thank you.
Yeah, thank you. Also, you mentioned about the assessment of preterm infant behavior.
Yes.
And this is, you mentioned started from day zero?
So it can start from day 0, but generally it's going to be a little bit older infant, usually 1 month of age, up to, 1 month corrected age is what they'll look at.
Okay, so
So
one
yeah.
month
Mhm.
corrected age. Yeah.
Yes, and that's some of the
Also,
early scales that I mentioned in the presentation.
do you have like any videos or any article how to do this assessment?
I would have to look and see. I don't have anything that I have right access to, but I can look and see if there's anything out there on that particular test.
Okay. Also, you presented the neonatal research network calculator, and I find it very nice. And but I think we mentioned in between brackets member login. So this is only for your hospital, or we can anyone can use this calculator.
I think anybody can use that calculator. I found it online. You know,
Okay.
just yeah.
So thank
And
you.
there are others as well too, but that's just a nice example of one where you give the baby's birth date and you give the date of your assessment and it comes up with what that adjusted age is.
Yeah, thank you. Also here, another question from Hala. I hope you have time. Still, you have
Yeah,
time?
yeah, I'm
Yeah,
good.
it is actually it's very interesting. Thank you. AA is mentioned in some babies which has CLD, chronic lung disease, and on preterm formula and poor weight gain in max total fluid intake, as example 180 ml per kilo full feed. Any suggestion to increase the weight?
So, I mean, when you're looking at babies who are having persistent problems with feeding, then you really are looking at that suck swallow reflex, looking to see what that coordination is. Some of our babies we need to do both NG feeds, or with some kids that really are having difficulty with aspiration or other problems, even a gastrostomy tube. So there are other ways to feed, but you definitely want to see what you can do with occupational therapy and feeding first, and see what they could do with maybe a different type of nipple or a different type of feeding system. And then with some babies, the next step would be to add an NG tube feed if needed as well too, to get the weight up.
Also, we can ask the help of the dietitian. They sometimes change the formula to high energy formula. Sometimes they
Absolutely,
add,
yeah.
yeah.
And
So,
different supplements
mm,
for express breast milk as well
yeah,
too. So yeah.
yeah. So, Hala is mentioning about 45 EPM. Any concern on neurodevelopmental growth? I don't
Not
think.
at all. I mean,
Yeah,
if that baby is
yeah.
getting breast milk, that's better than not. So, yeah, fortified breast milk is actually what is recommended for these babies, and actually helps them with some of their physical growth, which in turn helps their neurodevelopment.
So, Dr. Ali mentioned also one nice question. Actually, we start to in our unit about the taking the stem cells from the cord, and some parents are very happy to donate the stem cells from the cord. So Ali is asking, what is the role of infusion of cord blood derived cells to reduce brain injury? Autologous allogenic.
That is a really great question, and I have no idea what the answer is, because again, I'm looking at when these babies leave the NICU. I think that that's a really fascinating idea. I don't know what the research is on that, but if that could be again one of those neuroprotective factors and something that's going on there, great. I would have to look up the research on that, and
Yes,
it'll be.
still is something is going on. Even one of my friends in Japan also, they had
Mhm.
started to have this research about the stem cells, and we can see.
Okay.
Uh, Again, Ali is asking role of early neuroprotective agent like erythropoietin, melatonin to reduce brain injury.
And those are, again, these are right now, they're experimental, they're being studied. We don't have any really good literature on what the outcomes are, but the idea that we are looking at interventions in the NICU to help protect neurodevelopment is actually great, and really far from where we were 10, 20 years ago. So it'll be very interesting to see what some of these studies show.
Yes, you also mentioned about the Pele score, and you mentioned it take 10 to 15 minutes which I really wonder, because we think that Pele scoring or make take more time than 10 to, because if it take to 10 to 15 minutes, it's very easy to use, and but our thinking it take too much time than this. So is it different, or it is modified Pele score, or what? Or this is
So that's a good question. I mean, a lot of that is really where you're doing that. And again, we are looking at this as kind of a neurodevelopmental follow-up clinic with these babies, as opposed to actually in the NICU where you don't really have 10 to 15 minutes to be doing development type of work in through there. The other thing is that the more you do some of these tests, the quicker you are at actually doing that, and the more accurate you are as well too. So again, and it's a suggested screen. There are other screens that are out there that may be helpful as well.
Yes, in our neurodevelopment clinic, every patient had 1 hour slot, so we have a good time for these babies,
That's great.
and we do questionnaires also. So I know the scoring or the scale sometimes it is subjective, and because different from person to person. Also the questionnaire, which came from the family, and sometimes they don't give the right answer because they don't mm, want to make their baby like behind the score.
Right,
So
right.
do you believe in the questionnaire more, or on the real tests we do by our eyes?
So every questionnaire that you get, whether it's parent or whether it is, directly assessed, you have to take in the context of what you see with that baby. So, and you have parents that go both ways. You'll have some parents that will answer questions to make their child look like there's more delay, and others that look like less delay. And it gives you some information about the family, first of all, and then you have to use your own assessment in there too, to really look and point out what's going on there. This is again where your neuro exam makes a big difference, because the family may say that he's using both hands to reach out and grab things, and you can show that family that the child is only using the right hand and not the left hand. So I mean, this is where you can actually help teach the family in terms of what to observe as well too.
And I think
So
it's also difficult because it depends on the mood of the baby while the exam
yes,
itself.
yes, uh-huh.
Sometimes it go for the other side. Like he do something at home, but while in the clinic he will not do anything.
He's not going to show off. Yeah,
Yeah,
uh-huh.
yeah. So we have Rina asking about do you start early neurodevelopmental neurostimulation for extreme premature babies while still in the NICU, even they are neurologically asymptomatic?
That is, a lot of NICUs are doing that now, where they are actually having OT or speech see those babies and um, start to do some neurologic stimulation with these babies, with a few little exercises, with maybe listening to music, with other sorts of sensory sounds. A lot of the kangaroo care is really focused on that as well too, because the best sound for a baby who's neurologically intact, or a baby who's not neurologically intact, is that skin to skin, hearing that mother's heartbeat, hearing that father's breathing, having that contact there, we know is very neuroprotective.
Also, one question, very also nice, because I had worked before in NICUs on with single rooms. So she's telling great, I don't know his YA, great lecture. What do you think of the impact of single rooms in ICUs on neurodevelopment?
Well, I think that, I mean, if you've got a single room and you've got, say, 20 babies in that room, you're going to have a little bit of sensory overload. And I think this is where we've got places where there are resources, we're trying to cut down on the number of babies who are in a room because of the sensory overload. At the same time, you know, a baby who's just in quiet, what does that do for them as well? So babies need to have a little bit of some sensory interaction, but maybe not what we used to have in terms of lights on 24/7 and, no time for any kind of circadian rhythm.
Thank you. I posted again the feedback form on the chat. Please fill up the forms and you will get your certificates. We need to finish. I want Dr. Colin to speak about Peace Academy and also about some innovation because you mentioned to me that you are linked to many innovation practice for assessing this babies neurodevelopmentally.
Absolutely. So the Peace Academy, Peace stands for Pediatricians Across Education, Across Continents Education. And this was actually started by a colleague of mine from Iraq back during the pandemic when we had, no opportunity for in-person education. And we started doing a series of webinars. And we found the webinars are still very helpful because you can do it from wherever you are. But we do have an annual conference. This year it's going to be March 28th and 29th in Abu Dhabi. We have it in different places each year where we have basic pediatric topics, but also some cutting edge pediatric topics as well too. And Peace really wants to give us a forum to talk to each other for mentorship. So many of our more senior pediatricians are mentoring junior pediatricians, and that's happening across the world. So we have American pediatricians mentoring Iraqi pediatricians, but we also have UAE pediatricians mentoring Canadian or American pediatricians. So they're things we all can learn from each other. And the idea that pediatricians across continents can teach things that just within our own country we might not get is what's really important. So
Thank you. And this is the purpose of our even meetings that we are
yes.
sharing knowledge across the world. Yeah.
Mm-hmm.
So
And
about
then
the innovation.
innovation, yeah. So there are a couple of different innovations that are out there that I do work with. One of them is a device, software as a medical device that is validated for children 18 months to 6 years of age in the diagnosis of autism. And what it does is it collects information from the parents via questionnaire. There are videos of the child that are uploaded, and they are viewed by a master's level or above trained video analyst. And then there are questions from the pediatrician. And the device is called Canvas DX. It actually has a 90% sensitivity or positive predictive value for diagnosis of autism. And actually even more important, a 96% negative predictive value. So if the device says the child doesn't have autism, then they generally don't have autism. So that is one area that I'm working in. I'm also working with a company called The Happiest Baby, and they have a product called the SNOO, which is a crib that will put a screaming baby to sleep in a minute. And it will help to rock and calm that baby. It has wings to keep that baby on their back so that they're sleeping in the most safe position. And there is some very good research happening right now looking at sleep induction and sleep lengths and brain maturation and really looking at this as a tool to help women who've had previous history of depression, anxiety to keep from having a lot of postpartum depression. In the United States, we're using it as well too, to use it as a non-pharmacologic therapy for babies who may have been exposed to opioids. So some of the things that I'm doing with it.
Yes,
Yeah.
something amazing actually, and
Mhm.
enrich the follow-up and very beneficial for the babies. So I hope maybe one day we have a workshop for these things that we can see by our eyes and know how it help and how it work.
Okay.
Thank you a lot. I'm really happy to see you today, and too much appreciation from the audience about how the uh, you are a great speaker, actually. Thank you so much, and hope
Well,
to.
thank you to everybody for your attention and your questions, and thank you for everything you do for these babies every day.
Thank
And
you.
thank you, Tariq.
Just one thing came on my mind before we
Yeah.
stop. When you work in the neonatal unit, every every decision you take, um, it affects the future of these babies. And it's really sometimes, like for me, I like wait and see, and sometimes I don't like to interact immediately to anything, because whatever you do, really, it will affect the future, either delay or you do the things fast. So really, in our neonatal world, really, everything you do for the baby matter later on. So you manage the baby now, and you manage his future. So just be updated. Just take care of every
So
decision you
important.
make.
Yeah.
Yeah, yeah,
Hmm. Being
yeah.
very
Thank you
mindful
so.
about it. So
Yeah, yeah.
thank you so much. Thank you to everybody. And until
Thank you.
next time, thanks.
Yeah, thank you so much. And again, the reminder that the feedback form on the chat box, and you can start submit your feedback, and you'll get your certificate. Thank you so much. See you soon. I think I have a promise from you. We can talk about many topics related to neonates later on.
All right.
Thank you,
Thank
Prof.
you.
And
Take
it was
care.
very nice to see you. Thank
All
you.
right.
Thank
Okay.
Bye.
you,
Bye-bye.
Professor Kraft.
Bye.
Thanks, Tarek.
Yes.
Thank you. Thank you,
Mhm.
Maggot. Thank you. Bye bye.